Good morning, class. Today we're going to be talking about coronary artery disease, and I have a brief outline outlining some of the major facts that you will need to know in caring for someone with coronary artery disease. First of all, it's very important to understand the causes of this disease process. Atherosclerosis is really a term which means hardening of the arteries. This occurs because there is a blockage of the blood flow that supplies the coronary muscle with blood and therefore oxygen. It usually starts by deposits of lipids within the intima of the artery. When this lining gets injured, inflammation occurs and we have the whole clotting cascade that develops. Ultimately, a thrombus develops, and the thrombus enlarges and blocks blood flow to the myocardium. Because there is blood flow lacking, there is a lack of oxygen, and the heart muscle can die. This is what is meant by a myocardial infarction. We have many risk factors that lead to coronary artery disease. Modifiable ones include smoking, hypertension, hyperlipidemia, hyperthyroidism, and diabetes. Both of these medical conditions can be controlled. We have recreational drug use that includes amphetamines, inactive lifestyle, obesity, and high glucose of over 100, psychogenic factors such as depression, anger, and stress, and elevated homocysteine levels. Non-modifiable risk factors include being a male. We do have coronary artery disease that's more frequent in males before the age of 65. After the age of 65, there tends to be an equal proportion of males and females with coronary artery disease. Ethnicity is also a factor. This disease process is more common in whites than African Americans, and the Hispanic population has a decreased incidence of poor outcomes from coronary artery disease. There are more incidences of this disease process in advanced age, especially in postmenopausal women, and there seems to be a genetic predisposition for people inheriting coronary artery disease. And most of this has to do with the way they manufacture and store lipids within their bloodstream. This slide shows you the coronary artery circulation. It's important to see that there's two main branches. This slide shows the coronary artery circulation, and the most important things to gather from this slide are the fact that there are two main branches of blood supply that break off from the aorta to supply the myocardium with oxygenated blood. We have the right coronary artery and the left main coronary artery, and anyone that's gone to the cath lab or given report to a coronary care nurse will sometimes hear the abbreviation RCA or MCA, main coronary artery or right coronary artery. From those arteries you see many branches branching off, and all of these can supply the myocardium with oxygenated blood. It's important to know the area of the blockage because we can anticipate care for the patient and we can anticipate different outcomes that might ensue as a result of a blockage in a certain area. Now, just how do we determine if somebody is actually having a heart attack or not? Well, there are many clues. As we've talked about before, as a nurse, we are detectives, and we look at data, we look at clues, and we put certain clues on one side of the fence that might state that the patient is having a heart attack, and we put different clues on the other side, which might lead us to believe that it's a completely different cause. Things that point towards a myocardial infarction are anything that stimulates the sympathetic nervous system. We have pale skin, clammy skin, increased heart rate, diaphoresis, nausea, vomiting. Radiation is another factor. Usually, and not usually, but often, cardiac chest pain will radiate to somewhere on the trunk, the shoulder, the arm, the jaw. I've had patients present with just a toothache or just maybe pain in their elbow. Usually doesn't radiate much further than those areas close to the heart because of how the nerve pathways are. They also describe their pain as crushing or aching as opposed to sharp. often they'll say their pain is a squeezing type pain. I've had women come to the emergency room and say they just feel like their bra is too tight. They feel like the old adage, you may have heard this before, as an elephant sitting on their chest. That's kind of how they describe their pain. There is often no precipitating factor. Cardiac chest pain, presenting as an MI, often has no precipitating factor. They might say, hey, I was just watching TV, or I was reading a book, and suddenly this pain came on. The other thing to know is what makes this pain better or worse. Symptoms of a myocardial infarction, they cannot be replicated and they cannot be relieved with rest or positioning. Whereas in a minute we're going to talk about angina, and those symptoms can usually be relieved with promoting oxygenation to the heart muscle. Pain that's a myocardial infarction will last between 30 minutes and up to 12 hours. So somebody that says the pain has been constant for the last 3 or 4 hours, you're going to want to listen to them. And then in very, very big myocardial infarctions, the patient may present with a decreased level of consciousness. Just what is the difference between a myocardial infarction and angina? Well, the difference is in myocardial infarction, the cardiac cells have died completely. The muscle is basically gone. It's dead. Sometimes it can be reperfused with interventions in the cardiac cath lab, but often it is too late. In a myocardial ischemic event, as an angina, there's a momentary blockage of blood flow to the coronary artery. And this is usually precipitated by stress, exercise, sex, temperature changes, such as a very cold temperature. The symptoms generally don't last more than 15 minutes. After about 15 minutes, there is blood flow that makes it through the coronary artery and supplies that myocardium with oxygen. There aren't usually any kind of GI symptoms such as epigastric distress, diaphoresis, nausea. There's not often shortness of breath or the anxiety that accompanies an MI. There's some variants of angina. There's something called Prince-Meadows angina, which occurs at rest, and that is usually a result of the coronary artery spasming. And then in women, they have a particular type of angina called microvascular angina. There is also something called unstable angina, and that is angina that occurs usually at rest, and it occurs in an unpredictable fashion. Often people that have angina will have angina every time they walk to the mailbox and get their mail, and the pain is always relieved when they sit on their couch and rest for 5 minutes. That's just an example. For unstable angina, their pain won't be relieved in the usual fashion, and it may occur at unusual times, so it's not as predictable. And unstable angina is a very concerning condition, which often can result in a myocardial infarction, which is irreversible damage to the myocardium. I had a third column here. I just wanted to briefly talk about symptoms that might point themselves away from either angina or a myocardial infarction. And those are any kind of symptom that can be reproducible, such as pressing on the chest, having a patient cough, having a patient take a deep breath. All of these things can indicate that the pain is coming from a different area, such as the lungs. Often the patient will complain of pain when you touch their chest a little bit harder, and that could be a musculoskeletal problem. So you want to definitely go through your PQRST evaluation of chest pain to determine what is provoking it, what is the quality of their pain, what does it radiate, how severe is it, and how long have they had the pain. All of these assessment factors are going to give you clues as to whether it is a myocardial infarction, angina, or if it is due to a completely different cause. We also have EKG findings, and it's very important to get a 12-lead EKG. This process in your nursing education, it's not important that you understand in detail how to interpret a 12-lead EKG, but there's a couple things you do need to know. Myocardial infarction can be diagnosed from a 12-lead EKG when there's ST elevation in 2 or more contiguous leads. And that ST elevation has to be greater than 1 millimeter. And in a minute, I'll show you some diagrams of that below this area we're on right now. ST elevation is indicative that there is extensive damage to the myocardium that is likely going to be permanent. We can also have an abnormal Q wave, and that is a widening of the Q wave or a T wave inversion. These factors are very important for the nurse to be able to recognize and to be able to report to the physician right away. In many of your hospitals, you may have heard over the loudspeaker, STEMI to the ER, and what that refers to as ST elevation MI has come to the emergency room, and all forces need to come into play in order to help that patient. Often they're rushed to the cath lab. There can be ST depression or T wave inversion in angina, and then if it's totally non-cardiac whatsoever, we won't typically see those findings. Although I do want to stress that an initial EKG may also be normal in a myocardial infarction. Sometimes it takes time to see that ST elevation or that abnormal Q wave or T wave inversion. So a normal EKG only means that more testing is needed. It does not rule out an MI. Laboratory data that you'll need to know and be aware of are, number 1, troponin. There's 2 different types of troponin, which is a protein that's released into the blood when the heart muscle is damaged. There's troponin I and there's troponin T. It's going to depend on which hospital and lab that you're working with, whether they're going to do a troponin I or a troponin T. The main thing to remember is the troponin T stays in the bloodstream and for a longer period of time. Therefore, you can think of troponin T equals time than the troponin I. But they are both very, very sensitive markers, and in fact there's many articles and different research out on which marker is better, and I don't even think the cardiologists have agreed. So you just need to know that an elevated troponin is a very strong indicator that the patient has had an MI. There can be some false positives, such as in renal disease, but you do have to take into account the whole patient picture in order to see whether the patient has had an MI. Troponin is almost always likely a factor that's going to rule in the patient for a myocardial infarction. The other main lab value to know is CPK-MB, which is another protein that's released into the bloodstream when the heart muscle is damaged. And this is a specific marker for the coronary muscle, and that usually rises in about 6 hours after an MI and peaks in about 18 hours. Third, there is a myoglobulin that is released, and that one peaks within 3 to 15 hours. Out of all 3 of those lab values, the most important one for you to remember and know is an elevated troponin almost always will rule in an MI. Conversely, in an angina or chest pain presenting that's a different cause than cardiac altogether, you are not going to see that cardiac marker elevation. And in fact, you might see other lab value changes, such as if it's a pancreatitis or acute gallbladder disease, you may see some other lab values that are abnormal. I want you to look at these 4 different diagrams of EKG changes that can occur in MI or angina, and just be aware, again, it's not necessary that you understand these completely or become an expert at interpreting EKGs. The most important thing for you to be able to note is an ST elevation, which in these last 2 bottom slides is exactly what we see. We see an elevated Q and T wave that's above the isometric line, and you can see a very good diagram of that right below. I'm going to conclude our first part of Cardiac Clue lecture, and I'm going to restart again when we talk about treatment for cardiac disease, part 2.